Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. We got Drew and Mark here again. We're going through another clinical case. This one's going to be one less straightforward than our previous to some degree. So assumption's going to be here, fellas. Patient has been seen in another clinic. Lateral elbow pain. They were treated about 8 visits, pretty much going after lateral epicondylgia, repeated kind of loading on the extensor mass. The symptoms that you find as they're coming in is 50-year-old lateral elbow pain, worsening with reaching and mild neck stiffness. Obviously has not gotten better with repeated loading of the extensors. That's why they're coming to see you. So, Drew, what are the first things that you want to look at here with this patient?
I would probably want to know if they've been dry needled because it's like magic for this. Just kidding. I'm being a little facetious. But you said pain with reaching, right? So the first thing I want to look at is, are you treating the right thing? Because if it is truly some sort of a loading issue, that soft tissue, the musculotendon unit, that should start to make some sort of a difference already. But the fact that there's pain with reaching seems kind of weird to me. So I would definitely be looking more central, anything from cervical or some neural tension, like the radial tunnel, to see if there's anything else going on that would likely have been missed. Because if they used a good loading program, some education, some health, or some general lifestyle things, which could be another thing to look at, I would say this should be getting better. So looking central, cervical, some nerve stuff, and then lifestyle, like overall loading. Are they changing anything, or have they done anything different with their overall lifestyle? What did they do at home? What do they do at work? Because that can sometimes perpetuate some of the pain and limit progression. So that's my first things.
Yeah, I love it. Mark, what else you want to look at?
I don't think I'll look at necessarily anything else different than Drew, but I think one of the thoughts that crossed my mind is the neck stiffness is, becoming more relevant in this case now that we know that the lateral elbow loading wasn't effective. But in my experience, cervical radiculopathy can either just start with neck stiffness and then send symptoms down the arm, or it can be like a progression, meaning like it used to be in the neck and now it's moved down, and now they don't have like neck pain, but they've got some stiffness there and the pain's actually in their arm. So, I think it's becoming more relevant with more information that we're getting from the patient.
Yeah, I think that's good. Obviously, when it's coming from another provider, as you guys are kind of alluding to, you got to screen the neck out. So I think we have a nice cluster that's been validated with radiculopathy around. I think they even had a shortened one that was the Sperling's upper limb tension test and abduction relief that I saw over the weekend. That's actually gotten some pretty good numbers, strictly from a cervical radiculopathy standpoint. But yeah, and the other side of it too, I really want to know weakness. I'm going to guess if it is coming from the neck, there's going to be some weakness somewhere. So, are we looking at myotomes? Have we looked at the reflexes to see if there's anything jumping off the page? And just kind of taking those quickly to see, that we can somewhat imagine that we're probably treating the wrong area, but you also still don't know, is this the loading process hasn't been great too at the last place they were doing it. Maybe they were just burning the heck out of that tendon and not giving it recovery time too. So being able to really get those, but I hear you guys. Screening the neck obviously is the one that's jumping out to us in terms of things that we need to look at. I like the neural tension component and looking at that, also looking at the neck joint itself. All right, so you kind of looked at a couple of things that you're screening at. Just as one to throw out here, we don't typically, I know you guys, we don't typically think about scanning this too quick or referring this off, but I think it's important that we really know and are able to talk that through. So when would you potentially scan this patient? What things would you be seeing?
For me, like if you're going through the dermatomes, myotomes, reflexes, that's going to be kind of establishing your baseline. But if you're noticing worsening of those symptoms, that's when I'd be a little bit more concerned. Or if they get more positional, meaning like the way I'm thinking about it is like they've got a space occupying lesion, and like every time they do something very specific, like they get like electrical shooting pain that like doesn't match with what I would typically expect from like someone with like a cervical radiculopathy.
Yeah, I'm kind of on that same one. But one thing I always want to keep in mind is like a myelopathy, something from the neck. If there's progressive neurological deficits, that would be the biggest thing. If they fit that kind of prediction role older, or maybe they have some other stuff going on, gait gait wise, some weird reflexes.
Yeah, it's interesting. I think through I mean, I don't know if you guys feel the same way, but a lot of times I'm less concerned with pain than I am weakness, right? I mean, and when it comes sort of for the big nasties to some degree. But at the same time, I want to make sure that I'm giving it the awareness too, as you said, Mark. I mean, there can be an infection, a space occupying lesion, something going on there. And unfortunately, if this patient was seen for 8 visits elsewhere, he could already be, months, weeks, 2 months outside of when this came on too. I think the big thing for me is weakness, right? They tell you, and I've also been struggling to pick up a coffee cup for the last 2 months. I mean, now we got a little bigger problem, right? I want to treat you, and I think that I can help, but our clock has already ticked down pretty good, and it may be this one where you actually are kind of treating and referring as well, and hoping that yeah we get some good gains here really quick because I don't want to see that weakness that's been lasting a while lasting any longer. It's 50-year-old, so they're kind of in that age range that's getting a little closer to where we got to be a little more guarded as well too on some of those things, which I think is really helpful. Curious for you guys, when you're thinking about looking at neural tension versus specifically at the neck, how do you guys screen out between where that tension is coming from? What are you guys going to go to?
Well, I will say specifically in this case, when you're dealing with lateral elbow pain and you do a radial nerve biased upper limb tension test, that already puts them in wrist flexion, which may be provocative if it's lateral elbow or radial nerve. So typically what I will do is keep their wrist in neutral and get a little bit more shoulder depression to bring on some neural tension, and then see if it reproduces their symptoms. And then I can still do sensitizing maneuver from different areas if I want to. But that's something that early on in my career I definitely missed, because I would wrist flexion somebody and they would already have symptoms before I even really got into my full test position.
Mine's not much different. It's looking at the joints that are non-related, shoulder depression, elevation, neck movements. If that significantly changes the pain in their lower elbow, that's where I'm saying, this is probably less likely to be a contractile tissue thing and looking more at the neural component.
Yeah. Yeah, I think that's good. I'll throw one other little curveball out just because I've seen it strangely enough very often, a couple times a year. I want to dig in that infraspinatus because every once in a while I'll get a referral of infraspinatus right to that lateral elbow. And I feel like I have seen people get cervical spine surgeries when they're actually just getting referral points from rotator cuff. Yes, you guys obviously good points there on other ones as well too. I think those are awesome screens, and I think we can tackle this patient well. So good stuff. Until next time, fellas.